I'm very pleased to introduce our keynote speaker. Dr. Shelley Bulletin is the director of the Center of Vaccine Preventable Diseases and an associate professor at the Dalla School of Public Health and the Department of Laboratory Medicine and Pathobiology at the University of Toronto. She is also a scientist at Public Health Ontario. Shelley leads a multidisciplinary research program aimed at evaluating whether our population is adequately protected from infectious diseases. Focusing on population immunity and vaccine effectiveness, this work aims to determine our future risk for outbreaks and epidemics. Shelley has a particular interest in measles control and elimination and has worked nationally as well as internationally in this area. In addition to working in academia, Dr. Bulletin has worked in public health at the provincial and national levels, focusing on infectious disease surveillance and public health emergency response. Now, please join me in welcoming Dr. Bulletin.
Thank you so much for having me back. I'm going to share my screen. Thank you. And just go into presentation mode. Perfect. Okay. Aisha, you can see everything okay?
Perfect.
Awesome. Okay, so I'll kick off. So today we're talking about flu. Just before we start, I am going to talk a little bit about disclosures that I do at the beginning of every talk related to my work on vaccines. I'm a member of several advisory boards and management committees related to immunization and immunization research, but I haven't advised or consulted to private entities. And the Center for Vaccine Preventable Diseases, which I direct, is supported by the university, but also supported through other sources, including grant funding and some funding from vaccine manufacturers. The university has a robust set of governance processes to make sure that the center can stay independent. Okay, so today we're talking about influenza virus, which is a respiratory virus that is seasonal. It causes a substantial burden of disease all around the world. It's estimated there are 1 billion cases, of which about 3 to 5 million are severe. And generally for flu, when we're saying severe, we're saying, lower respiratory infection or hospitalization. And annually, it causes an estimated between 300 and about 650,000 deaths. So a lot of morbidity and mortality for this virus. Today, we're going to be talking about influenza A and influenza B. So I'm just going to take a second and explain how we classify flu, because this comes in later when we talk about how we vaccinate for flu. So for flu A, we usually classify flu A by which kinds of receptors the flu virus has on its surface. So if you look at the bottom right here, there are 2 types of proteins that face the outside, and that's what our immune system sees first. One is hemagglutinin, or HA, and the other one is neuraminidase, or NA. Now, there's a lot of different hemagglutinins and neuraminidase. There have been 18 hemagglutinins and 11 neuraminidase types that have been detected. Most of them are really just found in species that are natural reservoirs for flu, like wild birds, for example. But they can mix and match and produce new strains and potentially cause new pandemics. But today we're focusing on seasonal, and generally for flu A, we're talking about H1N1 or H3N2. Now, flu B is also, it has a hemagglutinin, it has a neuraminidase, but we classify it a little bit differently using lineages. So the B Yamagata lineage and the B Victoria lineage. Really interestingly, it seems thus far that the COVID-19 pandemic has made B Yamagata go away. So it has not been detected since March of 2020. So it is possible that we won't be seeing it again. And as a result, the WHO last year started recommending that we actually don't even include Yamagata in our vaccines. So in Canada, we think flu infects between 5 and 10% of adults every season. Before the pandemic, we don't have great data for after the pandemic, but before the pandemic, it caused about 12,000 hospitalizations and 3,500 deaths annually. It's transmitted by respiratory route, aerosols, and direct or indirect contact with respiratory secretions. It has a fairly short incubation period, but it is infectious from 1 day before until about 5 days after symptom onset. So someone can do some real damage in terms of infecting other people before they know that they're sick themselves. The classical symptoms of flu are fever and a cough, and then one or some or all of sore throat, joint pain, muscle pain, exhaustion. And in young kids, we can also see gastrointestinal illness sometimes. So one really important thing is that flu activity is seasonal. We see it in the winter. It's one of our winter respiratory viruses. This is a figure showing flu activity in Ontario from 2022 to 2025. So basically starting at the end of the pandemic. Two main takeaways from this figure. First of all, flu A, which is the darker orange, usually causes a lot more disease than flu B, which is the lighter orange. As you can see, the peaks are quite different in size. And then the other thing to note is that they usually don't happen at the same time. So usually we have a wave of flu A, and then we have a wave of flu B. And they can be far apart, or they can be close together, or sometimes they are at the same time. But the point here is that even if you're late on getting your flu vaccine, even if it's January and you haven't gotten it yet, you may still be protecting yourself against the flu B that is likely going to come. Okay, so in terms of what circulates in Canada, again, it varies by year. And this figure shows the distribution of flu A and flu B from 2014 to 2023. And although there are differences by year, we see that most years there's more flu A than flu B. So either H3N2, flu A in orange, or H1N1 in blue. And, there are varying amounts of flu B depending on the year. In terms of who is most impacted, severe disease is most common in the oldest in our population and the youngest. And here we have hospitalization rates for flu during the 2023-2024 year. On the left, we have flu A, and we see that the group with the highest hospitalization rate is adults over 65. They can get very, very sick from influenza, in particular H3N2, but both. And that's really because our capacity to make an immune response decreases as we age. We are more likely to have severe disease, more likely to have underlying conditions that may get worse as a result of infection. On the right, we see flu B, and we see that the group that is most likely to be hospitalized is actually the youngest individuals under 5 years old. We also see, if you compare the y-axis, that there's a lot less hospitalization for flu B. We have 4 types of flu vaccine, and you may be seeing any of these in your clinic, so I just wanted to go over them quickly. First, we have egg-based vaccine. So this is the traditional vaccine that we have been making for decades. Virus is injected into eggs and grown in eggs. And once there's enough virus, it is inactivated, so essentially killed. And sometimes it is split or made into subunits to just break it up a bit so that most of what your body is seeing is hemagglutinin. Next, we have recombinant vaccine. So this is where we take the hemagglutinin gene, we put it in an insect cell, and then the insect cell makes a lot of that hemagglutinin as a protein, and then we isolate the hemagglutinin and we put just that into the vaccine. Third, we have cell-based, which is kind of a combination of the two. So we are taking flu virus and we're infecting mammalian cells. And then we, as when we have enough virus, we kill the virus and inject mostly the hemagglutinin. And last, we have live attenuated influenza virus. This is quite different than the other 3 because it is a live vaccine. So there is a flu strain that is attenuated, which means it doesn't cause disease. It's not very pathogenic. And we put it in the nose, so it's a nasal administration. And this vaccine, that the flu vaccine strain, replicates at colder temperatures. So it doesn't multiply very well in your body, but it'll give you a little bit of a runny nose because it replicates well at around 25 degrees. So flu vaccine composition is updated annually, and that's because flu is always mutating. We call that genetic drift. So the genetics drift over time. And then sometimes we have genetic shift, which is a really abrupt shift, and that's usually associated with a pandemic or a new strain emerging. And also because immunity is not super lifelong and it wanes between seasons. So twice a year, the WHO gets together and decides what's going to go in the vaccine. And the way that is done for us in the Northern Hemisphere is they look what is currently circulating in the Southern Hemisphere, because our winter is their summer and vice versa. So in February of every year, they say, here is what is going to go into the flu vaccine this year based on what we're seeing now in the Southern Hemisphere's winter. And then it takes several months to produce adequate vaccine supply. And this is a figure of just all the steps and how long it takes for egg-based vaccine. Now, sometimes the virus mutates in the meantime. So between the time that we decide what we're going to put in the vaccine and then like basically now, October, the virus can change a lot. And so that means some years the effectiveness of the vaccine is different than others and maybe better or maybe worse. So just looking at how the vaccine did last year, we are looking for Canadian data from the last flu season, so last winter, and the Southern Hemisphere's winter, which was our summer 2025. And we see that in Canada, H1N1 and H3N2, so essentially flu A, had a 53 or 54% vaccine effectiveness. And we actually didn't have enough flu B to generate a vaccine effectiveness estimate. In the Southern Hemisphere, we see similar vaccine effectiveness for H1N1, and we see a little bit of a lower VE against hospitalization, and 62.3, so fairly good for flu B. So we usually look at these numbers to project what is going to happen, but with flu, we never like to make any predictions because we're usually wrong. So in terms of what the WHO has recommended for this year, they have recommended 2 flu A strains and 1 flu B strain. They have not recommended a B Yamagata strain because, as I said, we have not seen this since the pandemic. And really the only new virus is the H3N2, which has been updated. Okay, so every year the National Advisory Committee for Immunization makes a recommendation about flu vaccine. There's a statement that is written every year that is excellent if you want to brush up on your flu. And they're saying that flu vaccine should be offered to anyone 6 months or older, including, or in particular, individuals that are high risk of severe disease or high risk of hospitalization. And some examples are pregnant people, long-term care home residents, and First Nations and Inuit and Métis people. Those who are more likely to transmit flu to high-risk individuals, so if you're a healthcare worker or if you're living or caring for someone who is high risk of severe disease, people who provide essential community service, and lastly, and this is a little bit newer, although we did see it in previous years, people with occupational or recreational activities that may increase their chances of encountering H5N1, which is avian influenza. Now, the seasonal flu vaccine does not protect against avian influenza, but what we're trying to do is prevent a situation where someone has seasonal flu and then they're exposed to avian influenza and the virus reassorts and creates something new. We want to stay away from that. So that's a means of helping us prevent the next strain. Now, in individuals who are 65 or over, NACI recommends high dose, adjuvanted, or recombinant flu vaccine as a preferential recommendation as opposed to regular flu vaccines. However, if it is unavailable, the recommendation is to use the standard dose vaccine because any vaccine is better than no vaccine. Okay. So in terms of what is happening in Canada, what is regulated, there are about a dozen or just short of a dozen flu vaccines that are available that have passed regulatory approval. In individuals, so looking at the top row, in individuals who are 6 months or over, there's a lot of choice, of course, depending on where you live. You might not get all of it, but there are inactivated formulations, cell-based formulations, recombinant, and live attenuated influenza viruses. That's just in some provinces, not others. These are going to be either trivalent, so 2A's and 1B, or quadrivalent, 2A's and 2B. It's a standard dose of hemagglutinin, which for those who are interested is 15 micrograms. Generally speaking, they're eligible for individuals who are 6 months and over, but it's a good idea to read the fine print because some of them have a narrower age eligibility. So for example, live attenuated influenza vaccine is only for individuals who are 2 to 59 years. And just a reminder that anyone who is between 6 months and 9 years and getting their first flu vaccine needs to have 2 doses at least 4 weeks apart. For individuals 65 or over, we have different options as recommended by NACI. So we have the high dose vaccine that is very similar to the standard dose vaccine, but just has 4 times as much antigen, so 60 micrograms. We have the adjuvanted vaccine, which is the standard dose with what we call an adjuvant. An adjuvant is like an immune booster. So you give it along with the vaccine, and it makes sure that that hemagglutinin stays in your arm a little bit more, causes a little bit more inflammation compared to a vaccine without an adjuvant, and makes a better immune response. It is a great way to boost immunity, particularly for older individuals. And the last kind is recombinant vaccine, and that has 3 times the standard antigen. Influenza is a really very, very safe vaccine. Adverse events are generally limited to injection site reactions or feeling a little bit headachy for a day. And generally, there aren't many serious adverse events. And just to demonstrate this, I pulled out data from adverse events reported per doses distributed in Ontario in 2023. So we see that the province gave out 3.7 million doses, and any adverse event, including, just a very sore arm, were reported at 1 person per 25 doses. And serious events, so basically hospitalization, were 1 per 200,000. And it's important to remember that this reporting, really all you're reporting is that a medical episode happened after receipt of a vaccine. So we don't actually know that they're correlated, we just know that they're temporally associated. Okay, so we know that sometimes during flu season, there are several vaccines that we want to give to get ready for respiratory virus season. Flu vaccine can be co-administered with, before, or after other vaccines and or RSV monoclonal antibody. Sometimes when we put a new vaccine out, like RSV a few years ago, we asked that if possible, it was given separately so that we could really monitor which adverse events would be related to RSV vaccine or not. We are done with that, and we can co-administer, which I think makes things easier and most accessible for everyone. Live attenuated influenza virus, because it is live, it can be administered with, before, or after any of the live vaccines or inactivated vaccines. Just a couple of notes about when you're giving multiple vaccines on the same visit. They should be administered in separate limbs if possible, or separated by at least 1 inch, and of course, each with a new needle and syringe. Okay, so I find that the best advice for getting the flu vaccine is personal advice. I personally get the flu vaccine every single year. I do it despite not having any underlying conditions. And I do it because flu is a miserable disease. And if I got it, I would be very, very sick. I would miss work. I wouldn't be able to take care of my kids. And, that's how flu is, even if it's uncomplicated. So I really prefer to avoid that. This means that I protect not only myself, but also my family, so we all get vaccinated. Here's a picture of us getting flu vaccine a few years ago, and my daughter really is just in it for the lollipop, but that's okay. I also really care about protecting those that are at higher risk of severe outcomes. So the people who are dear to me who are older, these are my in-laws, Judy and Bobby. This is them last week getting their COVID vaccine because they haven't been able to get the flu vaccine. It's just rolling out now. And we talk about how to make vaccine decisions every fall, and I recommend the flu vaccine, the COVID vaccine, and they've already had the RSV vaccine. So having their flu vaccine last year, Judy and Bobby cut their risk of medically attended influenza by half, which is very, very significant. So, that's all the more reason to get it for yourself and for everyone else. Some helpful resources. The annual statement on flu for this year from NACI is available. There's also a supplemental guidance specifically for individuals who are 65 years and older. The Canadian Immunization Guide has a separate chapter for, every vaccine as well as special populations. There's also the Canadian Respiratory Virus Surveillance Report, and that is if you want to see what's circulating. On the right, I put the link for the Sick Kids Immunization info line. This is an info line that is available to anyone who has a question about vaccines for children. So if there are vaccine hesitancy concerns or contraindications, it's a wonderful, wonderful resource. And I believe that it's also available in several languages. And that is all. Thank you.